anterior segment surgeries experience the thrill. So we have different topics which includes penetrating keratoplasty, merging complex DSEC surgery with SFIOL, managing iris, pupil and lens all in one go, managing pediatric traumatic cataracts, managing post-RK and post-LASIK cataracts, and steering out of the mess, managing LASIK complications. So first I would like to introduce Dr. Nidhi Gadkar, who is a cornea, cataract and refractive consultant at in Kashyap Memorial Eye Hospital. She'll be talking about penetrating keratoplasty with the title PK, but not just PK. Over to you, Dr. Nidhi.
Thank you, Dr. Nikunj, for making me a part of this wonderful IC. A lot of us young surgeons are trying to get out of our shell and do challenging cases. And this is just a presentation of few of them. I have no financial interests. So I'll be talking about PK and more. Now, a normal penetrating keratoplasty may include just removal of the host cornea button and putting a new, can you dim the lights please? And putting up a new donor tissue and doing the suturing. But sometimes, in spite of adequate preoperative investigations, there are a lot of surprises that may lie beneath the cornea. So in a routine OT, I usually keep the following at hand: a standard power PMMA IOL or a multi-piece IOL, 9O or 10O Prolene sutures with straight and curved ends, vitrectomy with trocar and cannulas, and intravitreal antibiotics. So this is a case of a 30-year-old male who deferred therapeutic PK advice by me for 7 months and then presented back with a large anterior staphyloma. This staphyloma was hindering the closure of lids, was cosmetically very disturbing to the patient, and if you can see, it was quite bulging out. So I planned a tectonic graft. The staphyloma was too big, so trephination was not possible. So first I deflated the staphyloma, and then trephination was easily done. Here a 13.5 mm trephination was done. The cornea was then cut into quadrants. Inferiorly, the iris was totally plastered to the cornea. Superiorly, the rest of the iris was saniculized and careful dissection done not to cause further trauma to the iris. Lens was subluxated for more than 180 degrees. Did an anterior vitrectomy inferiorly and tried to dislocate the lens. But superior zonules were pretty much intact. So started a capsulotomy and then eventually removed the nucleus with the bag. Now there was a lot of bleeding and blood clots which were not going with washing. So I used a vitrector and removed all the blood clots. Found iris at the healthiest point and planned to do a iris repair to avoid PAS and further increase of IOP. Did it at 2 places. Completed the anterior vitrectomy and did the suturing. So this is at day 3. Quite a lot of haze because of the hyphema. And this is at day 7. PR was inaccurate because of long-standing high IOP, but nevertheless, cosmetic result was good. Coming to the next case, this is a case of chronic PBK for more than 10 years. Limbus does not look too good, but patient was very highly motivated to undergo a surgery. So did a UBM and saw that the IOL was tilted. Ultrasound was okay, mild vitreous echoes. Did a VEP and found that amplitude and latency was also normal. So went ahead with the full thickness penetrating keratoplasty. On cutting the host, to my surprise, there was no IOL. There was a fibrotic posterior capsule with a pre-existing rent adhering to the iris. So I did a gentle cyanicolysis. Retina surgeon not available, IOP too low. No way to make scleral flaps now. So thought of doing a pinhole pupilloplasty for this patient to achieve maximum visual outcomes. Did the anterior vitrectomy and removed all the fibrotic capsule in the optical axis. And then did the suturing. This is the look at 3 weeks. Pinhole vision and unaided vision is counting finger 2 meters, but with plus 10 it is 6/18. Sutures are on. Patient was very happy. This is another case of a long-standing corneal abscess treated for over 2 months outside. There are multifocal infiltrates reaching up to the limbus almost. So here again I thought of doing a large diameter therapeutic graft. Removed the half of the cornea and kept a hinge to see how the anterior chamber looks, and the lens had quite a lot of exudates over the anterior capsule. Tried to remove this. If not, then ECC would have been done. Looked at the equator, because sometimes when we remove the iris and there's a long-standing hypopyon, these exudates might reach up to the pars plana, which requires a lensectomy, vitrectomy. Coming back to my case again, inflammatory membranes over the iris were removed, and now started the positive pressure. The graft was large, patient was young, mannitol was given, but still there was a very high risk of expulsive hemorrhage. So I sutured back the host and now put viscoelastic over the host and placed the graft over the host and sutured at 4 new quadrants. Then slowly release the sutures of the host, and without damaging the iris or the lens, pulled out the host. Now the chamber was closed and it was quite easy to suture with no positive pressure. This is the look at day 10. At 2 months, now at 6 months, his graft is failing, so he will be posted for a DSEC or optical triple. Now sometimes there's a large corneal abscess which is almost perforated. Care needs to be taken here because, like in this case, first suture for the Fliringa ring and the lens is out. Now this is a sticky situation, so first I made the graft and then started dissecting the host. Tried to keep the lens at its place for as long as possible to avoid a longer duration of an open sky. Dissected the iris from the host. Thankfully, the anterior chamber did not have much exudates and the iris also looked healthy. Vitrectomy machine was not available on that day. So I did a manual vitrectomy and did the suturing. At the end, I checked for any Cyanicia or any remaining vitreous tags, completed the vitrectomy, and closed the case. Now, this is a case of a normal optical triple. Rhexis was complete, rigid PMMA IOL in the bag, but due to long-standing pupillary dilatation, the lens is coming in front of the iris and there are iridocapsular adhesions. Now, this will lead to an optical capture and will cause a problem. So I tried to do a cyanicolysis for this case. Injected Heal-On between the iris and the IOL. Very gently tried to remove the Cyanicia, trying not to damage the lens or the bag here if possible. And thankfully 360 degree I could achieve the release. Pupil was constricting. Iris looked healthy, so did a single 4th row pupilloplasty. Straight needle passed 9-oproline by railroading, and it went well. Heal-On is easy to remove. So this is at day 7. Again, the pupil here is a little dilated, and this is at 6 months. Patient has unaided vision of 6/18 with sutures on right now. So to conclude, you need to always be ready with all your armamentarium because you don't know what lies beneath. That's all from my side. Thank you for your patient listening. Over to Nikunj.
Amazing. Yeah, thank you, Dr. Nidhi. That was an amazing presentation as well as collection of surgical videos. And being a cornea person myself, then when we open any therapeutic case, especially, it is never just only PK. There is something or the other. And even in optical cases, but if generally I have seen that most of the therapeutic cases, there is a lot of surprises we get when we remove the button. So another, for the benefit of audience and for other people also, that I would like to know, what do you prefer when you plan a triple procedure for IL calculation? What is the method, how you do the IL calculation? Do you take the other eye measurements, or like is there any other way? What is your preferred technique?
Mostly we would take the other eye, because here the cornea will be scarred, or it's not possible, or it's a regraft many a times. Otherwise, we can take the axial length and take a standard keratometry and then do the calculation. So that also has a lot of surprises. Sometimes it fits quite well and vision is quite good, but even after the calculation, I would still try to keep the patient more on the myopic side.
Right. And what is your way of removing sutures? At like, what do you follow? Or like at what months, and how do you go for suture removal? Do you do topography based and then selective suture removal, or how do you do it? Like, take care of the astigmatism part as well?
Yeah, for optical cases, first of all, we would like to keep the sutures till 1 year. If there is excessive astigmatism, then topographic guided suture removal can be done. It can start from 3 weeks as well. But I still wait, because I'm still new to this. I wait for at least 3 months, and then according to the topography, I would do in few of them. The other thing is, when you're doing topographic guided, you want them to come back again to you. So people who are living too far, that might be a problem. In therapeutic cases, if there's a large graft with multiple sutures, most of them will get loose. If there are a lot of sutures, you can remove few of them. If vascularization is starting, or sometimes some sutures are repeatedly getting loose at particular areas, it's better to remove them, else they'll attract vascularization and then trigger a graft rejection.
Joy laptop, please. So that was an excellent presentation by Dr. Nidhi. Now we have Dr. Subhajit Bhattacharya, who is a pediatric ophthalmologist and cataract and anterior segment surgeon as well at Disha Eye Hospital in Kolkata. He'll be talking about managing pediatric traumatic cataracts in a non-traumatic way. Over to you, Dr. Subhajit.
Thank you, Dr. Nikunj. It's a great honor actually to be talking over here. And let's start the morning in a constructive note. Present as weak as present as you can.
इसको क्लोज करिए पूरा आंखों करिए
So I'm going to talk about the handling of pediatric traumatic cataracts. So I'm currently working at Disha Eye Hospitals. I would like to acknowledge the surgeries by my wife, Dr. Ketki Subedar, as well as my co-surgeon, and special courtesy to Sitapur Eye Hospital. As we know, all trauma cases are very different. However, together, if we consider all the scenarios, we can divide every single case into a few similar micro situations. we can dissect all these micro situations into a few general surgical steps, and we're going to talk about all these single steps one by one. First, let's start with the posterior Cyanicia handling. So as we know, most of the traumatic cases, blunt or penetrating ones, they're associated with some sort of posterior Cyanicia. Weak Cyanicia, which we quite often find, can be gently released pretty simply by a spatula. A strong one, however, they might be associated with bridging membranes. They need to be cut, and we should not try to pull too much, otherwise they have the risk of iridiolysis. Iris hooks will reveal the underlying cataract. Strong peripheral Cyanicia quite often may hamper the IOL placement, so we need to anticipate such a difficulty, and we can right at the start cut off the iris. It should not be pulled, otherwise it may cause the risk of dialysis. Sometimes we come across very thick fibrocyanicia associated with fibrovascular plaques. These need to be assessed carefully with the help of spatula first to extend to understand the extent of the adhesions. And once we figure out the extent, they can be cut off with the help of a micro scissor, or a vitrector will be very helpful in such cases. I personally would not like to put a primary IOL on such cases, because I would anticipate inflammation in such cases. Coming to anterior capsular management, it should be calm and controlled. Ruptured anterior capsule is a pretty frequent finding in most of the trauma cases. As we see over here, there's a membranous edge which can be cut, and the rhexis can be rounded off with the help of a micro-rhexis forceps or an Utrata, whichever comfortable for the surgeon. And for this, we use the technique of grasp and re-grasp, as we know for most pediatric surgeons, as in otherwise the rhexis might have the chances of running away. At the end, if we come across this membranous edge, we should not pull it too much. It should be just cut off simply. As we know, all pediatric cataracts, they have a very thin and elastic capsule. So remember, the pull should always be centripetal towards the center. Rhexis enlargement, this is a step which we have to do pretty often, as sometimes we have to put a secondary IOL as well. So we have to be very careful about the cut. Otherwise, if we go for the cut beyond the plaque, there's a chance of the rhexis running away. For this, I personally think it's a good idea to give 2 planned nicks and then place the IOL, and then give planned nicks and then round off the rhexis. So lens aspiration, coming to lens aspiration, should be like steady, calm, and slow and steady. I personally do a half and half thing. That is, one half I do the entire aspiration and polish thing. Polish should be done under low vacuum and clear of all the entire thin fibrils, and then go to the second half. This is just to avoid switching of hands frequently. And remember that most of these cases are associated with corneal opacity, so we should be careful enough not to leave underlying cortex. You can just tilt the globe for a better view and see the cortex beneath. Plaque management is a significant case in most traumatic cataracts. So for most plaques, we have to be first assess whether it has a plane of separation underneath or not. So if we find a plane of separation, then it is very easy to peel it off. So as we see over here, it can just be peeled off like a rhexis. We need to be careful about the underlying attachments. Most of these plaques are attached to underlying vitreous. So before pulling it off, we need to make sure that we cut off all the vitreous adhesions. And sometimes the plaque would not have a plane of separation. Such cases, we can just simply cut it off with the help of a vitrector or a scissor, form a sulcus, and then place the IOL on the sulcus. IOL implantation in such cases, it is mostly 3-piece. We need to anticipate difficulty and plan for a 3-piece IOL from the start only. The loading of the 3-piece IOL is a challenge itself. So we need to keep the trailing haptic outside. It's called a mustache sign. And for the entry, for the injector, we need to inject it initially with bevel down, turn it left initially. Then as we progress with the IOL, it need to be turned down and then turned right for the proper entry of the IOL. the trailing haptic should be kept outside to anticipate any untoward situation. And then it may be dialed into the sulcus. Posterior capsular management is mandatory in all traumatic cataracts. So if in case a healthy bag is available, so I personally do a retroial vitrorexis and vitrectomy. So I just place it into the capsular bag, and then with the vitrector I go underneath. Initially I make a small opening with the port down, and then with the port up, I would like to enlarge the posterior capsular opening, as we see, and create a visual axis. Anterior vitrectomy, personally, I feel a limited anterior vitrectomy is good enough, just a little bit enough to just disturb the vitreous phase. Thorough anterior vitrectomy need not be done. If there is absence of a healthy bag, then we can just create a good visual axis and place the IOL in the sulcus. As you see over here, this is a PC fluttering sign. This is a good way to identify the presence of vitreous. As long as the PC is fluttering, then we can figure out that vitreous is there. Once we see that the PC flutter stops, the vitrectomy is complete. Wound management has to be planned properly. Most of these cases are associated with thick corneal scars quite often. So such cases we need to anticipate and pre-plan the site of the ports, as multiple ports are to be planned in such cases, like multiple iris hooks ports. So it's best to avoid the site of the scars. Suturing is done mandatory for all traumatic cases and most pediatric cases as well. So we need to be very careful not to leave any leaks to prevent any chances of infection. I'm just concluding my talk with a few frequently encountered challenging situations. This is a membranous cataract with posterior Cyanicia, as we see over here. So initially the Cyanicia was weak, so we gently released the Cyanicia, washed off all the pigments, and there was a thick anterocapsular fibrosed capsule as well. So we had to cut it off and then do the rexis wherever possible, clean off the pigments. This is just, we're having difficulty with the rexis, so I decided to cut it off. And then the hydrodissection was done, and cortex was teased out. You have to tease it out, as cortex would come in bits. And then the cortex was aspirated with the help of Simcoe and by manual, whichever comfortable. And then underlying the plaque was visible. It was a thick fibrous plaque. So we could identify a plane of separation for this, like we talked about, and the plaque could be peeled off like a rexis, and adhesions were luckily not there, too many. And a clean bag was available to place the IOL in the bag. The post-op outcome was pretty satisfactory. This is another pretty commonly encountered situation where we had a pre-existing PC defect. So this is a surprise that we had in such a case. In such case, we would like this to call this an alternate cortex aspiration and a vitrectomy. So whenever you do the cortex aspiration and whenever you find hindrance, you can just do an anterior vitrectomy over here, liberal anterior vitrectomy, and then continue with the cortex. So alternate vitrectomy and cortex aspiration would really help in such cases. Be careful. Yeah, cut mode. So we have to be careful to not to direct the irrigation cannula towards the vitreous. It has to be away from the vitreous. The remaining plaque can be just cut off with a vitrector. Visual axis can be cleaned off, and the IOL can be placed in the sulcus, and the outcome was pretty satisfactory. So just to conclude, pediatric traumatic cataracts, we had done a small study in Sitapur Eye Hospital during our tenure. We had a pretty promising results over there. And as a conclusion, I would like to say it's a challenging situation. Every traumatic cases are very challenging, so keep all your weapons ready, and let's hope for good childhood outcome, visual outcome. Thank you so much. So, yeah, sure. I had done in a 16-year-old girl one SFI once. Yeah, so it was a bit of a mixed technique as well. I had Dr. Karan along with me. So.
Sometimes when you're removing the plaque,
So yeah.
an anterior capsule is not too good.
Yeah. So this one I had a grossly subluxated cataract. So could just we had a properly planned SFI from the start only.
That was an excellent presentation, Dr. Subhajit.
Thank you.
I would like to know a few tips from your side because for pediatric cases, even though no matter what kind of challenging cases you manage, the management isn't over because post-operative amblyopia management is the another most important part. So how do you take care of post-operative amblyopia management in such pediatric traumatic cataracts?
So basically, we have to assess the how much is the amblyopia and how much is the vision loss due to the cataract itself, due to the scars and all itself.
Right.
So we have to just maybe give an amblyopia trial. We have to figure out the extent first. So if it's most of the amblyopia, first of all, if it's more than an 8-year-old kid, then it's and the traumatic and it's a recent cataract, then there's not much of a chance of too much of an amblyopia. So we can presume that maybe the scar or the astigmatism, all these can be the cause of the poor visual outcome if it's there. If we see that the cataract is existing for more than a year and the child is still in a visually mature stage of life, then we assume that amblyopia could be a major cause of the poor outcome. So we would give a trial of patching, and we would see and monitor and observe for at least 3 months and figure out how much that is improving. If we see that the improvement is not significant, then we figure out we do not want the child to go through all that patching trauma and all. We would just taper it off gradually. That's it.
Right. Thank you so much. We have a few audience as well. If anyone wants to ask any question, ma'am. No, right. Okay. So next is Dr. Karan Bhatia. He is a cornea, cataract and refractive surgeon, currently practicing in Merit at Drashti Eye Foundation and Manaktala Eye and Maternity Home. He is also Secretary of Young Ophthalmology Society of India. He's my best friend. He's my mentor. He has trained me for all corneal surgeries, and he's still training me. And he's always be training me forever. Yeah. So he'll be talking about merging complex DSEC surgery and SFIOL. Over to you, Dr. Karan.
So thank you, Nikunj, for this opportunity. I'll get straight into the talk. Merging complex DSEC and SFIL. So a complex or a challenging situation in DSEC could be the result of an intraoperative complication or the challenging situation of the eye itself. Sclerafixated IOLs are a proper surgical approach for management of aphakia. IOLs claws are also pretty good. You can use whatever you are comfortable with, but these sclerafixated IOLs are a challenge for the anterior segment surgeons. So basically we devised the mixed technique, which is a modified adaptation of the Yamane and the XNIT techniques, where the flange is created by using a heat cautery, like the Yamane technique, and the IOL haptic is inserted outside the eye, like the XNIT techniques. So M for modified adaptation, Y for Yamane, and X for the XNIT. This technique recently also received the IGO Silver Medal Award, and it's really easy to do it. Anybody can do it. So we published this. This is the paper. We got a very good results. So we thought, can we combine them with keratoplasty? So this is one case, 23-year-old, one-eyed, post-strap, PL, present, PR accurate, and dependent on others for the simplest of tasks. So there's a thick fibrotic Descemet's membrane or retrocorneal membrane. There's 360 degrees of central and peripheral anterior Cyanicia. The question arose what to do. Would you do a PK over here or would you do something else? So this is the surgery itself. The step one is the decision making, that what you need to do is visualization. I need to decide. So this is an intraoperative decision that is sometimes made. An anterior segment OCT should always be done. It helps, or a UBM, to get an idea of the anterior chamber structures. See, now the epithelium is removed. I thought, let's give it a shot. Can I do something better than simple PK? So this is using a reverse Sinski hook. This this retrocorneal membrane was being stripped, and once that was done, then you can see that so then using an iris repositor, various anterior Cyanicia they had to be broken down, and you can see this membrane is getting stripped and separated. You have to be very careful, very gentle, slow movements, and you have to be really patient in dealing with such cases. So once this was done, you can see sometimes it's difficult to actually peel off this entire membrane. So scissors really helps. Micro scissor is pretty handy. So membranectomy is a good option in certain cases. So I've cleared the central area, and now I'm going to tackle this membrane. So this was cut with the scissors, and then it was removed using a McPherson's forceps. And you can see how thick this membrane is. It's extremely thick. See, now the anterior chamber structure, you can visualize it much better, the anterior chamber. So I'm like, now, yes, I can do something, an endothelial keratoplasty over here. There were multiple tags, so they need to be cut with a cutter. If there's vitreous prolapse, you need to do vitrectomy as well. And the next thing is what we did was, once this was done, then the next thing was the SFIL implantation. So this was a post-trab eye. So I didn't want to a failed trab. I didn't want to touch the conjunctiva much. There could be fibrosis there. So this is a 3-piece Orolab lens from Orolab. No financial interests. So using a 26 gauge needle, around 2 millimeters away from the limbus, this needle was brought out of the corneal incision. Around a 5.2 millimeter corneal incision, 5.2, 5.5, and this leading proline haptic was inserted into this needle lumen. Nikunj, Joy, Subhajit, Dr. Subhajit and I, we have done a lot of cases with this technique, and really wonderful results. So this was externalized. This PVC stopper, this is Nikunj's idea, the use of a PVC stopper. What we did was we cut the IV set plastic, and we used that for that. And on the other side, you did the same thing. And this trailing proline haptic was also inserted into the needle lumen, and gentle movements, very careful movements are required. An AC maintainer is always helpful. It becomes very difficult if you don't have an ACM, or if you have a PPV infusion, that is also pretty good. So you can see the IOL is well centered. After that, you need to trim the IOL because you don't want any pseudophacodonesis. Then you create a flange. This is the heat ballpoint heat cautery from the older days, and a flange is created, and this is buried intrasclerally. Similarly, it is done on the other side. The reason you need to trim the haptics is because you don't want any pseudophacodonesis, and because you want the haptics to be tight. If you don't trim this, actually there's externalization of this, so then you'll have to go again and then trim. We've done that in the initial cases, and then we decided on 1 millimeter, 1.5 millimeter, but is the cutting that you have to do, but you have to trim it according to the eye itself. Now the step came. Now the most complex part of the surgery was done. Now the other part is the dissect. But you see, the denticule did not separate completely, so that was another challenge. And then the graft turned out to be extremely thin. Dealing with the thin graft, the results are better with the thin graft, but it gets really difficult to sometimes manipulate these thinner grafts. So this, during a needle insertion technique or a push technique, this was put inside the anterior chamber, shallow anterior chamber, and then the graft was unfolded. The DMEC movements would come over here for the unfolding of the graft. Air was injected behind, to oppose this lenticule with the posterior surface of the stroma. And you can see it's opposed nicely. You can see the double ring sign that you get when the orientation of the graft is correct. So if you look at over here, this is day 21, this is what the patient did. The graft size is only 55 microns. The IOL is extremely stable. 636 was the unaided vision. And he improved by day 67 to 618 plus 2. You can see the flanges also over here. They are nicely buried over here intrasclerally. So the point of extrusion, no flap, this is where it comes out. The flange size is also important, slightly more than the size of the opening that would be created by a 26 gauge needle. He's doing very well. This is another case of PBK. A broken IOL was there. This IOL was also explanted, and then again we did the surgery. I'll skip that part. Yeah, but then sometimes after the SFIL has been done over here with the same technique, now there's an iris, it's a dilated pupil. I don't want to leave it like this because I'm going to use an air double. I don't want to go, it's a vitrectomized eye. I don't want it to go behind. So then what I would do is, I would do pupilloplasty at the same time. And Dr. Amar Agarwal's technique is, extremely beneficial in such cases, and it's helped us out a lot. Single pass 4th row. And then you can insert your dissect lenticule again, and then again oppose it using an air bubble, and this is how it was at the end of the surgery. Did pretty well. This is another case. This is that case. BCVA. This patient had by date for 241.69 was his BCVA. This is another case. ACIL. If it's damaging, you need to explant that ACIL, and you need to cut it out You can leave it in place, but if it's a recurrent problem, you need to take it out, and then you can do a desec. This is another case of a corneal decompensation, but there was a problem or error from the eye bank where the donor cornea turned out to be a microcornea. So we did it. We went ahead with the case, and these were the surgical steps. And patient also did extremely well. You can see this kind of the scleral part over here, and did pretty well, BCVA 6.9. So I'll end my talk by saying challenges are gifts, and they are opportunities to learn. Thank you.
So have you had any instances where the IOL has dislocated after giving too much of air tamponade?
No, I haven't had any instances so far. Yes, we've had in the initial stage one of the cases. It was a post PK I did. It was slightly decentered, but then we went ahead and fixed that. So the trick is you want the haptics to be taut. So yes, trimming of the haptics is extremely important. The IOL is going to be stable. The flange ratio, you don't want a too big flange also, because you want to bury it intrasclerally. So if it's a big flange, it's going to come out. It's going to come out extrusion, and that's a potential source for infection. You don't want that.
Thank you, Dr. Karan. That was an excellent talk. We are running a little behind, so I'll start quickly. So I'm Dr. NIKUNJ. I'm a cornea, cataract, and refractive surgeon at SRJ Netralia in Indore, currently practicing in Madhya Pradesh. I'll be talking about handling iris, pupil, and lens all in one go. I have no financial disclosures. In some normal cases where you have normal nuclear grade of NS2 or a mature cataract, just good phacoemulsification is enough and your job is done. But what will you do when you come across such cases where apart from cataract, you need to handle iris tissue, you need to think about reshaping the pupil, and you need to think about the long-term outcome. So you need to have certain instruments for handling such cases and specific type of sutures also for handling such cases, such as 10090 Prolin. You may get surprises during the surgery that zonules are weak and the capsule is not able to hold on its own, and then you will need capsular tension ring or a segment. For the stretching of the iris, intraoperatively you may need iris hooks. And always have anterior vitrectomy on a standby, because until these cases are over and the patient is out, and anything can happen during the intraoperatively. So there are various techniques of iridodialysis repair has been described in the literature, and I will be talking about just reattachment of iris to the sclera using mattress suture. It is quite old technique, but it is easy and it is just simple and does the job. So moving to the first case, he was a 22-year-old young male who came to us with a trauma by a large rubber, and I asked him, he told me that it was being used to tie a luggage to the trolley. He had a more than 180 degree of iridodialysis, and there was a hyphema in the anterior chamber. His vision was hand movement with PL only, and intraocular pressure was 35. So after control of inflammation and control of intraocular pressure, you can see the view got clear in the anterior chamber. Iris had regained some of its tone, but there was clearly evident more than 180 degree iridodialysis, and you can see a posterior subcapsular cataract and retroillumination. So I took this case to manage cataract and iris both. So first, inferior paracentesis was created, and high molecular weight OVD was injected in the anterior chamber. Then 3 superior paracenteses are made to use iris hook. So first you need to mobilize this iris from the center, because it is in our surgical zone. So it is important to be careful while putting the iris hook as well. So what I do is I invert the iris hook while it is passing through the iris, and then flip it again before hooking the iris. And be careful that you should not drag your anterior capsule along with the hooks. After that, the phacoemulsification with the slope parameter was done. There was nothing specific, anything about it. Following which, a conjunctival flap is created in the area where I'm going to reattach the iris to the sclera. So, and it is important to achieve hemostasis for better visualization, and I'm creating a scleral groove 1 to 1.5 millimeter away from the limbus, and creating a small Hoffman pocket. So this is going to help us bury the knot of the Prolin suture in that area. So following which, a straight 90 Prolin needle is being inserted from the inferior paracentesis, and using my other hand and a micro tying forceps, I'm stretching the area near the root of the iris before passing the needle. But this stretching part is most important because otherwise you will not be able to get the correct location of your suture tying area. And then carefully the needle is passed. Here I'm a right dominant person, so it was getting difficult. It sometimes get difficult to pass the needle from the sclera at the correct location. So then you can switch the hands. So now I've switched the ends after passing through the iris. I'm pushing the straight needle into the sclera and getting it out exactly at the scleral groove. That's where I want, because that's where I'm going to tie the knot and bury the knot. It is important to give counter traction using your left hand, and it becomes little difficult sometimes to get this straight needle out from the nasal area. So if you tilt the globe using your left hand, then the area of the exteriorization becomes superior and it becomes easier to get this straight needle out. Similarly, the other end of the suture is also being taken out from the same area, 1 to 1.5 clock hour away. Then I want another 2 fixation points. So I created a superior conjunctival peritomy, and similarly a double arm 90 Prolene suture is being used to first pass from the iris tissue and then through the scleral groove on the external side. So it is important that you need to get it out from the scleral groove. For the third attachment, it was getting little difficult because that area was difficult to access. So I use a different technique there. I'm using a 26 gauge needle, getting it passed from the scleral groove inside the eye first, and then passing through the sclera. And then I'll be inserting the 90 Prolene needle through that needle, through the 26 gauge needle, and I'm going to railroad it out. So this is also another easy way to get this needle out when the area where you are operating is little difficult to access. So that is another tip for that. So you can see I've created the 3 loops and get it out from the scleral grooves, and I'm going to tie them to the sclera, and it is going to fix the iris to the sclera. And always, if you can rotate the suture into the scleral groove, it is always better to bury into the scleral tissue. And you can see how the iris tissue has regained and pupil has regained the shape. So next thing is about pupilloplasty. So pupilloplasty, a few of my friends have shown here few cases, and there are various techniques of pupilloplasty. And most fascinating one I feel is the iris encerclage. But easier to do is single pass 4-through pupilloplasty, which is popularized by Dr. Amar Agarwal sir, and that is what I'm going to show here. So this is another case of 24-year-old male who had a history of trauma. I think it was a firecracker injury, and he had developed a traumatic cataract, mature white cataract. With the there was a loss of zonule with the zonular dialysis and equator visible in the inferior 3 to 7 clock hours. And there was loss of inferior sphincter completely, along with traumatic iris holes. And you can see after dilatation, the dilatation was good, but the equator and the zonules were visible from 3 to 6 hours. So I planned the surgery with the phaco aspiration and use of capsular hooks to stabilize the capsule intraoperatively and followed by capsular tension ring and IOL implantation and pupilloplasty. So it was an intumescent cataract, so it is important to decrease the intralenticular pressure by decompressing the lens using a 26 or 30 gauge needle. Use high molecular weight OVD like sodium hyaluronate to flatten the capsule, which will give us a better control over the capsular axis. I always try to perform capsular axis using a forceps or a micro-axis forceps, because you need to hold the flap and have a circular axis at the end of the procedure, because without that it will not be possible to use capsule hooks or capsular tension ring, because that is the most essential part. Following which I am using iris hook here to stabilize the capsule intraoperatively during the phacoemulsification. Here it was a soft cataract, so I used just an irrigation aspiration using a coaxial probe using low parameters. The bottle height was low and the vacuum and flow rate was also limited. And you can see how this fluffy cortex got separated from all around, and it is being aspirated completely. It is important not to let the chamber collapse before removing your irrigation source. So always inject OVD before coming out. Then the capsular tension ring of 12 mm overall diameter is being inserted into the capsular bag, which will stretch the capsule. And you can see how the capsule margin, rhexis margin, was getting detached from the iris hook, which is being used as a capsular hook here. So that shows that the capsule has moved to the equator now. Equatorial stretching has happened. So after removing the iris hook, a 3-piece IOL has been implanted. It gives a long-term stability. So I'm stretching the pupil here from all around. First, it is important to make the pupil into its normal physiological state, and then inserting some of our pilocarpine also helps. And then I'm planning a single pass for pupilloplasty suture here. So first needle is inserted from the opposite limbal area, and then it is being passed from the inferior iris tissue away from at least 1 to 2 o'clock or away from the inferior limbus. Then from the opposite side, I'm using a 26 gauge needle, inserting from the paracentesis and passing through the iris tissue near the pupillary border. Then I'm going to railroad out this needle. I'll just fast forward it a bit. So this needle goes inside the 26 gauge needle, and you can reload it out easily. Then important thing is which loop to bring it out. So the loop between the first entry point and the first pass from the iris is brought out actually, and the other end of the needle is cut, and the 4 throws are created. That will be a self-locking knot created, and then you have to just pull it gently inside the eye, and it goes in the area of the pupil. And this is actually a modification of Sipser's knot, but it actually works well, and it gives us tremendous results. So you can see how the iris tissue is being opposed, and similarly a second suture was also planned and being pulled inside, and you can see how the pupil has regained its shape. And these are the post-operative day 1 pictures of the patient, and you can see the pupil has regained good shape, and patient did good surgically and anatomically post-operatively. So this is just a photograph of another case. Due to paucity of time, I will not be able to show the video surgical management. So this was a 15-year-old boy who had a trauma by his teacher, because he made some mistakes. He was learning some Sanskrit slokas and everything, and he had a localized sphincter damage for 3 to 5 o'clock hours. You can see that in area, and he had a anterior subcapsular as well as posterior subcapsular cataract. So for cataract management was straightforward, and I did a pupilloplasty for him, and this is the post-operative picture, and he had regained a good vision and good anatomical outcome without having any much of a photophobia. So take-home message is for iris and pupil maneuvers, you need to learn the horizontal movements, because for phaco it is kind of a vertical movement. We are habituated to phaco and cataract, so it is important to learn those vertical movements. It is little difficult to do, but with practice you can master it. Think beyond just phaco and cataract, and be always confident to handle traumatic cases and keep testing your limits. For the audience, if you get any time in your free time, just check out Video Assisted Surgical Teaching. It is my YouTube channel, which has got detailed video of all those cases with narration also, and I have put a teaching video series for the postgraduates as well. Thank you so much. Yes, quickly.
As most of these cases are post-traumatic, how much pupillary dilatation do you achieve after doing the SFT to look at the posterior segment, and when can you dilate? Because post-PK, I've had few cases in which the suture got cut through because of dilatation of the pupil post-PK after doing SFT as well.
That is a very good question, and even I had questioned that myself. So I have followed up these patients. I have dilated them on follow-up as well. Generally, I don't dilate them at least for a month. If you can wait even more, if there is an indication, obviously go for dilated evaluation. But wait 1 month, obviously we should dilate and see if there is any peripheral retinal breaks, because there was a mature cataract. We didn't have a look, any look of retina preoperatively. So we did dilate the case, and the dilatation was, in the first case, there was a complete half of the inferior sphincter was gone. And you can dilate after a month, and dilatation is also pretty good. Like you can see a completely equator and even base of the vitreous. So next we are going to have a video presentation, because Dr. Tushar also has the instruction course at the same time in a different hall right now. So I'll be playing this. Will audio be available? Yeah.
So very good morning, and my gratitude to Nikunj for having me in his IC, and I'm sorry for not being there in person in the hall right now. I'll be talking about post-RK and post-LASIK cataracts and what is different about them. So the challenges that are involved in these cases include preoperative, intra-op, and post-operative challenges. So starting with the challenges that we encounter preoperatively. Well, the biggest challenges in preoperative evaluation in these cases is that of keratometry and IOL power calculation. Then there's also the dilemma of which intraocular lens to implant, whether we should go for a monofocal lens or a multifocal lens, and what should be the target refractive error in these patients. Now, the limitations that keratometers and placido topographers have in these eyes is that they are based only on the anterior corneal curvature. They don't really measure the posterior corneal radius, and they extrapolate that using an assumed ratio between the posterior and the anterior corneal radius. Also, they are blind to where the exact corneal center is, and they must extrapolate that information. This is where corneal tomography helps. And what I prefer to use is the Pentacam Holiday EKR map, which basically is designed to take into effect the refractive effect of the anterior as well as the posterior surface. And this calculates these values using the Snell's law, and the final K values that you get from this can be used directly into an IOL formula that is based on a refractive index of 1.3375. Now, this is what the holiday EKR maps look like. You have the AKR values in different zones centered at the pupil. You have various parameters against the mean zonal EKR. Then you have a histogram which shows the relative frequency of EKR. And then you have the EKR 65 mean and the EKR power map. So when you look at this cornea and try and analyze, you see the histogram has an extremely uniform appearance. There is a single peak, and the standard deviation also is extremely low. So this is quite a regular cornea. And if I get this cornea post LASIK and I have to do a cataract surgery on this patient, I would go for a multifocal lens. Now, this, on the other hand, is a much more irregular cornea. You can see that the histogram also is a little spread out. There is a peak, but there is a lot of variation, and the standard deviation is quite high as well. So in this particular patient, I would try to avoid a multifocal lens. I would want to go for a monofocal lens here, but I would be okay with going for a toric lens, because if you look at the K1 and K2 values in the different zones of the EKR map, you will see that they are quite uniform. So this patient, though, having an irregular cornea, would definitely benefit from a toric IOL. And I would counsel that, this is an irregular cornea, but I would definitely go for a toric IOL in this particular case. Now, in post-refractive cases, all you need to do is to feed these values into the ASCRS online calculator, which then gives you a measurement of the IOL power from different formulae, and you can take the average of that and use that for your calculations. Now, what should be the target refractive error for your patients? If it's a LASIK patient, I go for a plano target refractive error, because we are usually quite on point with these calculations, and you don't expect much of a refractive variation post-operatively in these patients. On the other hand, in patients who have undergone an RK, I try to target myopia, and the more the number of cuts, the higher I expect the post-operative hyperopic shift long-term to happen, which is why I would target a higher amount of myopia in somebody who's had more cuts. So with somebody with 12 or more cuts, I would target a -2 diopters of residual myopia. Now, in spite of all of these measures, and in spite of trying to get the best measurements and the best calculations, there are occasions where you really don't have answers. So, for example, this particular case was a 35-year-old woman who had undergone LASIK previously. Now she has a grade 2 cataract in both the eyes. So now, in this, with the optical biometer, I did not get any measurements. The axial length taken from the ultrasound shows that this is a high myope. And when you look at the pentacam, just see how flat this cornea is. So you have keratometry mean values of about 25, 26 diopters. And when you look at the EKR map, you can see that in some of the zones, the cornea is as flat as 21, 22, 23 diopters. So I went ahead and tried to calculate the IOL power using the ACRS calculator in this case, but the calculator refuses to calculate and tells us to check our values instead. Then what I realized is that the calculator doesn't accept any value lower than 31 diopters. So there is really no way to calculate these IOL powers with any formula in this case. So I did a little bit of trial and error. I saw how the IOL power was changing as I went from a keratometry of 31 to 32 to 33, and then tried to extrapolate how it would vary should I go to a more flatter cornea. And based on my assumptions and my extrapolation, it of course was not a precise calculation. I went for an IOL power of 21 diopters. So here we did have a little bit of hyperopia, but the patient was reasonably satisfied. And then we had to go for the left eye, and I tried to aim for a lower residual refractive error. So I went for 23 diopters. In this case, there was about zero 0.5 diopter sphere left. So all in all, reasonably good outcome, but always, difficult to predict this, and this could have gone wrong as well. Then the challenges that happen intraoperatively. So when you have post-RK eyes, the challenges that you face to begin with is where do you place your incision and whether you should go for a clear cornea or a scleral tunnel. So if it is an 8 incision RK or even sometimes a 12 incision RK, you can go ahead and place your incision between two RK incisions if there is adequate space for that. But if there isn't, you have to plan a scleral tunnel. Also, you should keep your parameters reasonably low. You don't want the incisions to be opening up because that is something that can always happen. Also, to the extent possible, avoid chamber shallowing. Try and inflate the eye with viscoelastic as you withdraw your probe, etc. When it comes to post-LASIK eyes, an important consideration is to take care of the flap. Make sure not to disturb it because you can have epithelial ingrowth, etc. later on if the flap is disturbed during the cataract surgery. The parameters, of course, would be as you would have for any myopic eye that you're operating. Now, this is a patient who is undergoing flax post-RK. In the anterior segment OCT, you can appreciate how flat the cornea is. And this is another patient who has undergone flax, though the incisions were made manually. So we are trying to aim for the incision being between the RK incisions here. The same with the side port, having it between two RK incisions. And in spite of all of that, you can still have these leaky incisions, as in this case, where you just have to suture the RK incision that is opened up. So post-operatively, this case was fine, and otherwise this was uneventful. Post-operatively, the challenges that you encounter are related to the hyperopic shift that happens in post-RK. And that is why you would rather have some amount of myopia post-operatively, because there is going to be a hyperopic shift happening with the patient, and the patient should be informed of this. And that can cause a hyperopic shift soon after the anything of that sort. Let that edema settle down, and you most likely will have the refractive error come down. Also, be aware and also let your patient be informed of the possibility of refractive surprise. No matter what measures you take, there can always be surprises in these cases, particularly post-RK. So to summarize, IOL power calculation is probably the biggest challenge, and corneal tomography and the ACRS calculator play an important role in being able to hit the target with these calculations in post-refractive surgery eyes. The challenge intraoperatively for post-RK eyes is where do you place the incisions and the possibility of leaky incisions, which does happen post-RK, in a cataract surgery post-RK. Now, refractive surprises are also quite possible, and the patient should be well aware of it, and if possible, try and get a special consent from the patient indicating that he has been informed of all of this. Thank you, and thank you so much for having me. Thank you.
So that concludes our session because we had one more presenter. Because of unavoidable medical emergency, she could not join us. So if we have any questions from anybody related to any topic, yeah. So thank you so much, and we'll have a group photograph. Yeah.